Chapter 1 discusses snoring and its relationship to sleep apnea, which is a potentially lethal medical disorder. Chapter 2 details the causes and consequences of snoring and sleep apnea with an analysis of some treatment alternatives. Chapter 3 introduces the silencer.
In the last 25 years, there have been major advances in the study and treatment of sleep disorders. Sleep disorders are now understood to be definable medical conditions which are linked to many physical and psychological ailments. The most common sleep disorder is snoring. One of the most worrisome is sleep apnea. These conditions are almost always linked. To many, snoring may merely be an annoying social problem or a subject for humor, but at its worst, snoring may be an indicator of sleep apnea. Studies in the U.S. suggest that just over 40% of middle-aged men and nearly 30% of middle-aged women are habitual snorers. And after age 60, these numbers climb to 60% for males and 40% for females. Snoring, even without apnea, can lead to numerous arousals during the night from obstructed breathing. And arousals have been shown to produce sympathetic nervous system activation. Snoring is also associated with an increased risk of hypertension, as well as an increased risk of both cardiovascular and cerebrovascular disease. In fact, apnea sufferers have 2 to 3 times the risk factor for cardiovascular disease and twice the risk for stroke. Sleep apnea is a condition in which, at numerous times during the night, the sleeper stops breathing for short periods. There are several distinct types of sleep apnea. Obstructive sleep apnea, or OSA, is defined as the cessation of airflow for at least 10 seconds due to recurrent upper airway closure, despite ongoing respiratory efforts. Central apnea is defined as the cessation of airflow for at least 10 seconds associated with a decrease in respiratory effort. Mixed apnea is a combination of obstructive and central apnea. It begins as central apnea but is quickly followed by chest and abdominal movement with upper airway obstruction. Hypopnea is a 50% decrease in airflow associated with a decrease in respiratory effort for at least 10 seconds. An hypopnea incident has occurred when the blood oxygen level drops by an amount greater than 4%. Obstructive sleep apnea syndrome, or OSAS, is defined as symptomatic OSA. Many people have apneas during sleep which are not pathological and do not produce any obvious symptoms or consequences. It is when apnea is frequent that symptoms generally result. Sleep apnea is often misdiagnosed as narcolepsy, which is a rare form of recurrent and sudden onset of sleep. Usually, significant OSA is defined as more than 5 apneas per hour of sleep or greater than 15 hypopneas per hour of sleep. Approximately 17% of male habitual snorers and 7% of female habitual snorers exhibit significant OSA. Patients suffering from OSAS don't spend sufficient time in REM sleep. REM stands for rapid eye movement. During this phase of sleep, only 2 sets of muscles are active: the orbital muscles of the eyes and the muscles of the diaphragm. Because OSAS sufferers don't get enough REM sleep, they don't receive the restorative and regenerative qualities of sleep. There are a number of risk factors for obstructive sleep apnea. OSA is 8 times more common in men than in women. However, the prevalence of OSA increases in women once they pass menopause. Obesity is also an extremely important risk factor. Craniofacial abnormalities such as facial trauma, retrognathia, and micrognathia are important, particularly in thin patients. Sedative or hypnotic drug use and alcohol intake cause relaxation of the upper airway muscles and increase the likelihood of upper airway obstruction. There may be a genetic predisposition. A person who has a first-degree relative with OSA runs a 30% risk of also having OSA. Diagnosis of OSA is made on the basis of an appropriate history and physical examination and overnight polysomnography. Overnight studies can take place at a hospital or sleep clinic or in the home. All decisions relative to the determination of the appropriate sleep study fall under medical case management. As such, they should be made by the patient's physician or sleep specialist. Treatment plans can then be coordinated with the patient's physician and dentist. The majority of patients with OSA present with a history of loud chronic snoring associated with a combination of witnessed nocturnal apneas, unrefreshing sleep, and daytime sleepiness. Because of the persistence of their symptoms, many people come to accept excessive daytime sleepiness as normal. Nocturia, decreased libido, and morning headache are common complaints. Other symptoms include poor memory, irritability, and poor concentration.
There were times when she'd have to poke me to see if I was still breathing, because I did have an indication of sleep apnea where I'd actually cease breathing, and I wasn't aware of this.
And I would lay there and I'd count 1, 2, 3, 4, and then I'd go and punch him sort of to see if he was going to be breathing again. And of course he'd go like this and he'd start breathing right away.
The cessation of breathing, I believe, hastened my heart problems. Certainly I was very young. I was only 46 when I had the double bypass operation.
We discovered I was unable to stay awake for any length of time during daytime, which was had some embarrassing features to it, particularly when you're working in an office. I'd fall asleep while I was talking on the telephone, or I'd be dictating a letter and I found myself falling asleep in front of my secretary.
The noise level of sleeping with a snorer of someone like my husband makes it impossible. It's almost as loud as a pneumatic drill when your head is that close to someone else's on a pillow.
Well, my motivation for seeking treatment was that I started to develop a fairly significant snoring problem. Wasn't as much a problem for me as it was for my wife. You know, she would constantly have to wake me during the night in order for her to be able to sleep. And it started off just an occasional, once a week, once every couple of weeks. And as time went along, I became a much more regular snorer. And so I started looking for answers.
What I understand it to be is a fusion of the vertebra, and X-rays show mine to be fused from C1 to C6. And that the hairline is low, and that the neck is short. And that's my understanding of the clipple fail, along with the limited neck movements. The symptoms I had that were most troubling were falling asleep at night and waking to gasp for air, or not being able to fall asleep and seeming to need air, having to actually sit right up in bed or sit over the edge of the bed. A terrific amount of nighttime breathing problems.
The most problematic symptom that I had with my snoring and sleep apnea problem was morning headaches. I used to wake up in the morning and have a headache, and as a matter of fact, in the course of the night I'd have a headache. I'd wake up in the morning and I would have this headache, which would last an hour or two after I got up, and then it would disappear.
Well, it's something I'm proud of, but then again it's something I'm not proud of. I've been in the Guinness Book of Records for 4 years, from 1990 to 93, as the world's loudest snorer. It's a dubious title to have. I went to my family doctor. My family doctor referred me to the University of British Columbia Sleep Disorder Clinic, and there they wired me up with bells and whistles all over my body and tested me out. And they just couldn't believe the horrendous noise that was coming through and the severe sleep apnea I had.
The causes of OSA have been clearly determined. With the subject in an awake state, the tongue is forward and the airway open. When the subject is asleep and prone, the tongue moves back, blocking the airway. Partial obstruction produces snoring. Complete obstruction results in an apneic event. In this MRI, the airway is shown as narrow but still open. During sleep, this patient will snore violently. The site of the upper airway closure is in the pharynx, between the nasopharynx and the glottis. Two of the more common areas for closure are behind the palate and at the base of the tongue. At sleep onset, there is a decrease in upper airway muscle tone. In predisposed individuals, there is a large rise in airway resistance as increasing respiratory effort is made. This leads to snoring, which is vibration of the airway soft tissue. Eventually, the airway closes and the apnea is sensed by the brain and arousal is triggered so that respiration can resume. The pattern repeats itself over and over during the night, in some patients, hundreds of times. The continuous cycle of halted breathing followed by arousal can lead to a number of significant physical and psychological problems. The result of an apnea is a decrease in oxygen level, and most apneas and hypopneas end with an arousal. Frequent arousals lead to sleep disruption and may produce excessive daytime sleepiness and impaired daytime performance. Excessive daytime sleepiness is experienced by many patients and may lead to cognitive problems, social and marital problems, and a significant increase in motor vehicle and industrial accidents. Between 40 and 60% of patients with OSA have hypertension, and evidence suggests that untreated OSA is associated with hypertension even when other risk factors are controlled. Adequate treatment of OSA has shown to reduce blood pressure. Cerebrovascular disease and cardiovascular morbidity and mortality are more common in patients with OSA, and vascular morbidity is a leading cause of death in patients with untreated moderate to severe OSA. One study found a mortality rate of 37% in untreated patients with an apnea index greater than 20 per hour. This versus 4% in untreated patients with an apnea index less than 20. The mortality rate was 47% in untreated patients over the age of 50 with an apnea index greater than 20. As well, OSA may be an independent risk factor for neurological, psychological, and endocrine dysfunction. The treatment of OSA falls into three categories: medical, surgical, and dental. In the medical area, certain physical measures may be effective, such as weight loss, stopping smoking, avoiding alcohol, not eating late in the day, and eliminating nocturnal sedation. Pharmacological intervention offers little relief for OSA unless the site of the blockage is in the nasal area. In such cases, certain nasal corticosteroid sprays may be helpful. Nasal continuous positive air pressure, or NCPAP, was introduced in 1981. In this system, the patient wears a mask and a pump blows air into the mask at a predetermined pressure, generally between 5 and 15 centimeters of water pressure. The continuous flow of air acts as a pneumatic splint, which prevents the airway from closing in. While this gold standard of treatment may be 100% effective, many patients report problems with nasal infections, skin eruptions, and sleep partner disturbances. These problems have resulted in a decreased level of compliance by patients. Tracheostomy, corrective upper airway surgery, and uvulopalatopharyngoplasty, or UPPP, are all surgical options for the treatment of snoring and OSA. The success of these procedures often depends on patient selection. Other surgical procedures for these conditions include tongue reduction, tongue advancement, mandibular advancement, and maxillomandibular hyoidal advancement. All of these involve intensive and invasive surgery and are not readily available. The problems of long-term compliance with CPAP therapy and the limited success rate of surgery have led to interest in non-invasive forms of treatment that are safe and effective. For treatment to be successful, it must be comfortable and convenient, so that compliance is a natural step for the patient. The development of oral appliance therapy has been a major step forward in the treatment of snoring and sleep apnea. Dental appliances function in three basic ways. Some reposition the elements of the oropharynx which are involved in snoring and apnea: the tongue, the soft palate, and the uvula. Others stabilize these same elements. Still others stimulate and thus create tone in the genioglossus muscles. Let's look at some of these appliances in greater detail. Tongue retaining devices, or TRDs, use negative pressure to hold the tongue in a forward position inside a plastic bulb. There may be a tendency for the tongue to become sore and inflamed in some patients with continued use of these devices. Mandibular repositioning appliances come in a variety of designs and complexities and work by holding the mandible and consequently the tongue in a forward position during sleep. A relatively small anterior movement of the mandible, and thus the tongue, increases airway volume and can eliminate snoring and also apnea. Many of the available mandibular repositioning appliances hold the mandible in a pre-selected and fixed position. Fixed position appliances may cause problems for patients with temporomandibular joint disorder. Unfortunately, the same age group who may suffer most from snoring and sleep apnea also suffer from bruxism and TMJ problems. The silencer is a two-component articulated mandibular advancement appliance. The articulating element is a patented precision attachment. This dental device is designed to permit the advancement of the mandible through a controlled range of forward movement. The silencer overcomes joint and muscle problems associated with fixed position appliances by allowing vertical and lateral movements of the mandible. The silencer allows up to 6 millimeters of lateral movement and 1 millimeter of vertical movement while still holding the mandible in a forward position. The key feature of the silencer, which allows for this flexibility, is a patented precision attachment known as the Halstrom Hinge. The hinge is constructed from implant-grade 6-4 titanium alloy and carries a lifetime warranty for the patient. The Halstrom Hinge is the feature of the appliance which allows and controls the necessary movement of the mandible, while at the same time achieving sufficient advancement of the tongue to relieve both snoring and apnea. The body of the appliance is fabricated from a combination of elastomeric material and hard acrylic. The elastomeric material delivers a measure of comfort for the teeth and supporting structures. The hard acrylic is used to retain the hinge and also acts to increase retention with cross-arch bracing and to hold any necessary clasps. In addition, the cusp tips rest in hard acrylic, which acts to maintain tooth position. There are also hard acrylic bite pads, which are used to provide support to the dentition as well as the temporomandibular joint. In private practice, the silencer has proven effective in a high percentage of the cases treated. The silencer is effective because it moves the tongue forward and out of the airway. In this first MRI view, consider the patient to be in a supine position with the tongue crowding the airway. With the silencer set at 60% of the pertussive capability, the airway is more open. However, the soft palate and the uvula are still resting against the posterior wall of the pharynx. The silencer is now set a further 2 millimeters forward. The soft palate and uvula are now lying against the tongue, leaving the airway open and unobstructed. The silencer is now 2 millimeters further forward. The airway is even further open. This is an axial view of a small airway without the silencer. With the appliance set forward, the airway is much enlarged. The silencer allows gradual advancement of the mandible to open the airway.
There were times when she'd have to poke me to see if I was still breathing, because I did have an indication of sleep apnea where I'd actually cease breathing, and I wasn't aware of this.
And I would lay there and I'd count 1, 2, 3, 4, and then I'd go and punch him sort of to see if he was going to be breathing again. And of course he'd go like this and he'd start breathing right away.
The cessation of breathing, I believe, hastened my heart problems. Certainly I was very young. I was only 46 when I had the double bypass operation.
We discovered I was unable to stay awake for any length of time during daytime, which was had some embarrassing features to it, particularly when you're working in an office. I'd fall asleep while I was talking on the telephone, or I'd be dictating a letter and I found myself falling asleep in front of my secretary.
The noise level of sleeping with a snorer of someone like my husband makes it impossible. It's almost as loud as a pneumatic drill when your head is that close to someone else's on a pillow.
Well, my motivation for seeking treatment was that I started to develop a fairly significant snoring problem. Wasn't as much a problem for me as it was for my wife. You know, she would constantly have to wake me during the night in order for her to be able to sleep. And it started off just an occasional, once a week, once every couple of weeks. And as time went along, I became a much more regular snorer, and so I started looking for answers.
The symptoms I had that were most troubling were falling asleep at night and waking to gasp for air, or not being able to fall asleep and seeming to need air, having to actually sit right up in bed or sit over the edge of the bed. A terrific amount of nighttime breathing problems.
The most problematic symptom that I had with my snoring and sleep apnea problem was morning headaches. I used to wake up in the morning and have a headache, and as a matter of fact, in the course of the night I'd have a headache. I'd wake up in the morning and I would have this headache, which would last an hour or two after I got up, and then it would disappear.
I went to my family doctor. My family doctor referred me to the University of British Columbia Sleep Disorder Clinic, and there they wired me up with bells and whistles all over my body and tested me out. And they just couldn't believe the horrendous noise that was coming through and the severe sleep apnea I had.
She took my blood pressure and she just calmly read it. It was 122/82 and 124/80 and wrote it down. And I thought, gee, that's great. And it was some time later before I realized that in nearly 20 years, my blood pressure had never read out at that level.
It was just as different as day and night. It was like one night I didn't get any sleep, and the next night, I actually didn't get any sleep either because I stayed awake waiting for it to happen, and it didn't happen. It was absolutely amazing, absolutely amazing.
Since I've been wearing a silencer appliance, because I have stopped the sensation of breathing and I'm breathing normally while I'm sleeping all night, I wake up much fresher in the morning, and I don't have that grogginess. I don't have the dry throat anymore, the sore throat. I just feel like a different person in the morning.
When he started wearing the silencer, his results were immediate. I know not everybody's are, but his worked that night. And it was such an unbelievable thing to hear silence that I stayed awake listening to the silence.
Well, the silencer has made a complete change in my life. It's opened all of the vistas I used to have before. I no longer have the tired feeling. I sleep well.
Once I had the silencer appliance, I found that my sleep did improve though. And I found that in fact, where I didn't know that I was tired during the day, in fact, I really was. I was much more rested after wearing the silencer.
The effect of the silencer has slowly but surely been wonderful. I think between the two, for the jaw movement, for the ease of knowing the jaw moves, for being aware now that, especially when I go to bed and when I wake up, that I am actually breathing. It is actually now full breathing all the way through, and there are times I actually just like to lay and do nothing but breathe. It feels so good.
As far as I'm concerned, it's something that everyone should, who snores and has a problem where it's creating difficulties either personally or with their mates, they should really look into this.
Instead of stopping breathing 350 times pre-operation to 250 times post-operation, I'm down to 3 times in one 7-hour period. My oxygen level's gone from, it was a low of 14% all the way up to 96%. My heart rate was 122 at its worst, and now my heart rate, I'm in the 60s when I'm sleeping. Major, major differences.
Since I've had the opportunity to introduce this appliance to patients in my practice, one of the things that I particularly noted is that they have responded positively because they feel that I've contributed dramatically to improving their quality of life.